we're back again for today. This is Wednesday's lecture, the 22nd. This, as you can see, is from chapter 15, and this is out of Wilkins. I'm going to go ahead and divide this into two different lectures. So this will be the same material, just the second part of it will be for tomorrow, then for Thursday. I looked at our calendar, and I think we're good on time. I sure hope we're back before your final, and I'm sure you are wishing the same. So we'll see what happens. So like I said, this is going to be divided up in two parts. The PowerPoint, the whole thing is like 60 slides, so that's why I'm dividing it up in two. I'm trying to keep the material manageable, plus keeping the file size down. So again, we are covering chapter 15 in Wilkins. So we're going to be looking at arterial pressure monitoring, and that's pretty much what we're going to cover today. Tomorrow we'll talk about CVP and pulmonary artery pressure monitoring and a little bit on central line. Okay, we have a couple free little slides here. This did come right from Evolve website, so, but it's very thorough. I like it. Okay, so as you know from being out there so far, and I'm sure you'll get to see more, all this type of monitoring is done in the ICU. The most common would be the arterial pressure monitoring, so your ART line. I'm just going to say ART line, it's easier for me to say. And then a CVP. You still will be seeing swans, that's the pulmonary artery pressure, and definitely some central lines. So just remember, they really look at trends on patients, okay? I mean, we do have reference ranges for our numbers, just like everything else, but this is kind of mainly looking at trends. So it's helping us with our hemodynamic monitoring in our patients that are most critical. These values help us look at intravascular fluid volume, which is kind of related to the CVP. So if you want to put CVP by intravascular fluid volume, it helps evaluate cardiac function and our blood pressure, or our ART line, pulmonary artery wedge pressure, and our cardiac output. Helps us determine that, helps us evaluate cardiac function, and then evaluating a vascular function by our SVR and our PVR. And it can help identify sudden changes in the patient's hemodynamics status. So invasive monitoring is needed to obtain these accurate measurements. However, keeping in mind they're trying to make sure that the benefits outweigh the risks, because these are invasive. We always have to make sure that indeed it is something that's definitely indicated. Alright, so here are some reference ranges. I don't know, I'm having a hard time with my R's today. I seem to always have trouble with my R's. Anyway, this was again out of chapter 15. So again, remember reference ranges, and intracardiac pressures are pretty much the same for adults and children. Okay, so just keeping in mind of that. Your heart rate and your blood pressure is definitely going to vary significantly by age, but the intracardiac pressures, so like your CVP, your right ventricular pressure, your pulmonary artery pressure, your left atrial pressure, those are all about the same. So these are reference ranges that are obtained from studies on healthy people. So they may be neither normal nor desirable for a specific patient. Okay, this table is found on page 333 in your textbook, in your new one. I always have notes from the previous edition, but I've been trying to go through and update my pages. For some reason, I kind of like the older book a little bit better. So just keeping that in mind. So what works for Charlie in one bed, you know, number-wise, isn't going to necessarily work for Henrietta in the other bed. Don't ask me where I came up with those names. I'm hoping you guys are laughing. I'm getting really tired of talking to the microphone. All right, miss your smiling faces. All right, see, I feel like I could be a little more at ease kind of with you guys. I have to be a little, toe a little tighter rope when I'm now lecturing for the brand new group doing math and science. All right, aren't you lucky you get my little jokes? All right, so moving on. So this is Artline pressure monitoring. Okay, so we're looking at arterial pressure. Okay, so why are we doing this? Why are we putting in an Artline? One reason that I know of right off the top of my head, for personally for my advantage is, and for the patient obviously, is not to have to repeatedly stick them. Okay, so patients have to be poked, you know, every half hour, every hour. For an ABG, it's like, can we just put in an Artline? It'd be a lot more humane. We also like to use it for patients that are significantly hemodynamically unstable. Okay, patients that receive medications that affect the blood pressure. So if we feel that the cuff isn't really accurate or having difficulty, especially on lower blood pressures, it definitely gives us a more accurate measure. So keeping in mind, these might include patients with ARDS, severe hypotensive or even hypertensive patients, septic shock, and malignant hypertension. Alright, so what should a pressure waveform look like, an arterial one? We should definitely see on the left side, you should have a clear upstroke on the left side. So if you're kind of looking at the mountain there, the very first line is, or waveform I guess, is going down, but if you're looking at the full one with the peak and then kind of a little notch there, so I'm referring to the left side of that, the real more straight upright. And then the little notch there, you should remember that's a dicrotic notch, okay? Then a drop to the right. So, not sure if anybody remembers what the dicrotic notch, I'm sure some of you remember, hopefully most of you remember, what that represents. It's representing the closure of the aortic valve, okay? So, if the dicrotic notch is not visible, and the pressure tracing is dampened, and I'll show you examples of what that means, and it's probably inaccurate, and the pressure measures are likely lower than the patient's actual value. So again, always look at your patient. I mean, if you don't have a waveform, first thing you want to do is look at your patient and make sure they're still conscious and, you know, they have a heart rate and that, and then take a manual blood pressure. It's most likely the Artline itself has got, you know, we'll talk about different troubleshooting strategies, but there's probably something most likely wrong with it. So if not, obviously something's going on with your patient. For example, the dicrotic notch is going to disappear in some patients when the systolic blood pressure drops below 50 to 60 millimeters of mercury. So maybe their blood pressure is just bottomed out. So again, you know, your patient's probably not going to look so good if their systolic pressure is 50 or 60. They're probably going to look, you know, clammy, pale, maybe mottled, possibly even unconscious. So, but you know, there's a troubleshooting things that we'll be talking about coming up even right here on the next slide. So you have a pressure reading, but you're unable to draw blood. Okay, so these are different things that you might, if you're managing the Artline. The dicrotic notch is dampened. The pressure readings aren't matching with the blood pressure cuff, or you've completely lost the tracing. So, kind of 4 different instances here, and we'll talk about ways to troubleshoot. Now, keep in mind, with this particular video that you're listening to and watching, on YouTube, if you go back to the very first PowerPoint that's listed under course content for this day, which, what are we on? We are on day 5. The very first PowerPoint that's listed is the one that has the speaker notes underneath. So if you view it under PowerPoint, you can look under your tab under View and then Speaker Notes, so you can see the little notes that are underneath, because this one has a lot of them. Alright, so you have a pressure reading, but you have no blood. So what's going on? There's some different things. The artery most likely is in spasm. Possibly the vasopressors are causing the artery to clamp down. Is the patient really cold or getting poor perfusion? Maybe he needs more fluids to improve blood flow and to improve blood pressure. Or maybe it's just time to move the site. Look to see if the pressure transducer is leaking, which would give you false low readings. If the pressure transducer is too high, position-wise is what they're referring to. So pressure transducer is too high in position. I'll go over the position where it's supposed to be. Then you're going to have a false low reading, and if it's positioned too low, then you're going to have a false high reading. So the pressure transducer should be placed basically at the level of the right atrium. Okay, so about the 4th intercostal space, mid-axillary. That's about where the pressure transducer itself should be lying. And that's the same for a CVP or for a pulmonary artery catheter also. That's where they want to have the transducer being. So it's usually on a pole, so they level it. You'll see the nurses sometimes with a yardstick or whatever, or some type of leveler, that they're making sure that it's in line with the right atrium at about the 4th intercostal space. And then it's mounted on an IV pole, and it can kind of slide up and down, so it can be positioned where it needs to be. Alright, if you have a dampened dicrotic notch, like it's completely gone, it could be an air bubble in the transducer. You want to also make sure that the blood pressure readings are matching from the blood pressure cuff and from the art line itself. Try to draw blood from the site, and you can't get the blood. Again, it could be a spasm. Try straightening out the wrist. Of course, it depends where the art line is placed. Also, if the patient's too hypotensive and the systolic blood pressure drops below 50 or 60, again, you may not be able to see that dicrotic notch. So you're going to check for kinks, clots, over-distended tubing, low pressure in the flush bag, because there should always be pressure held in that bag. This type of tracing can underestimate the actual pressure reading. Again, if the pressure readings are not matching, is the location or size of the actual blood pressure cuff, is it the right size? Is it the right place? Making sure that the transducer is at the 4th intercostal space, which again, mid-axillary. Try repositioning the arm, making sure the dressing is okay, that it hasn't moved, or if it's kinked. So those are all different troubleshooting things that you will try. Also, just even if it is not your responsibility and you just happen to notice that something's leaking or blood, whether it be fluid or blood, always mention it to the nurse so she can check it out. Alright, so here's kind of what a dampened waveform is going to look like on the right side there. This other side is spiked, resonant trace. This is something else that you might see. This could be from increased vascular resistance. If you guys are hearing something funny, my stomach's making all sorts of weird noises. Increased vascular resistance or extra long tubing, non-compliant tubing, so it's really stiff tubing, or maybe the stopcock isn't fully opened, and this reading can overestimate the blood pressure. So they call it underdampened, is another term for it. Alright, here again are some different reference ranges for heart rate and blood pressure. and this is also on chapter 15. Okay, so taking note that as you get older, your blood pressure starts to go up, and as you get older, then your heart rate starts to go down. Alright, so where are we putting these arc lines? You'll probably see it in several different places. Radial probably being the most common. Ulnar also, so it runs parallel to the radial. Brachial, axillary, or even femoral arc lines. Okay, those are not totally uncommon. Again, most often placed in the radial. The radial artery is very readily accessible and has collateral circulation. With on the ulnar side, it's easy to monitor for bleeding and other complications. Femoral is less affected by vasoconstriction, so it's not quite as sensitive, but it is definitely more difficult to monitor, to keep clean, to watch for bleeding. It might be a little bit harder to detect leaks. Also, if the patient is prone for any reason, that would be definitely something that we couldn't do if the arc line was there. So remembering what we test for, I just have a little note here in my notes about what we test for when we do an ABG. Remember, we do an Allen's test to check for that collateral circulation. Okay, this is just an example of kind of what the whole kit and caboodle will look like here with the pressure bag that I was talking about. You always have to have pressure in there. You can see that little bulb to squeeze pressure. Otherwise, the blood pressure would push the fluid back out, or the blood back out. So they keep the pressure bag at about 300 millimeters of mercury. So the transducer reads the changing pressure and changes it into an electrical signal that can be interpreted on the monitor. The transducer sits on a holder or an IV pole, like I mentioned. It needs to be correctly leveled. It needs to be at the fourth intercostal space at mid-axillary. So the procedure of drawing a blood gas, they're going to draw from the through-way stopcock. The first 3 to 5 mils is considered waste because that's what's been sitting in the line. You get about 2 to 2.5 mils for a sample, and you make sure you flush saline back in the line. Make sure there's no air in the line. You want to make sure you've cleared out any bubbles, which would be the air, and also make sure you've closed the stopcock. I think that's probably something that happens occasionally. Alright, especially in our line, don't want to do that. Alright, so once inserted, the catheter connects to a disposable continuous flush device by a low compliance tubing, and then so what they usually do is then they just have a little bit of saline kind of running through that. The flush device keeps the line open by providing a continuous low flow of fluid, so it doesn't clot off. Okay, so about 2 to 4 mils per hour, which is just a teeny tiny bit. So if you hear, like, they'll say TKO, TKO is to keep open. Okay, so you might just have a line placed. It's just running TKO. It's just to keep it patent, so it doesn't clot off. Okay, so a pressure transducer then provides an electrical signal to amplify or to an amplifier or monitor, and that is what displays the corresponding pressure waveform. So again, the arterial pressure, so some of this is repetitive. I kind of merged a couple different PowerPoints. Mainly it's come from the publisher, but a couple of those other slides are from another PowerPoint that I had. So the arterial pressure wave should have that clear upstroke on the left side, and then you should see the dichrotic notch on the downstroke on the right. Okay, remembering that represents aortic valve closure. Again, it may disappear in patients. The diaphragmatic notch pressure drops below 50 or 60. If the diaphragmatic notch is not visible, the pressure tracing again is dampened and probably inaccurate. And the measured pressures are probably lower than the patient's actual value. So that's repeated from the last slide. When you're looking at the monitor, you will generally see the arc line pressure, or the waveform of the arc line pressure is generally in red. Okay, so you have the heart rate, you have the respiratory rate, you have the pulse ox waveform, and the arc line pressure is pretty much always in red. Oops, there we go. So arterial pressure waveforms may take on different configurations, and we kind of looked at this on some of those other ones here. When you have that kind of pointed top, it may show that there's an increase in circulating catecholamines that increase the contractility of the heart, and a tall, narrow pressure wave can be seen with patients that have a stiff aorta due to arteriosclerotic vascular disease, okay, or ASVD. Increases in heart rate and vascular resistance are obviously going to increase our diastolic blood pressure. Vasodilation is going to decrease then our vascular resistance and then cause a fall in diastolic blood pressure. And diastolic blood pressure is important because that is when most of the coronary artery perfusion is actually happening. Okay, so about 70% of the heart itself is being perfused during that resting phase. Okay, so that's why it's important to keep that number in a good range. So if that diastolic pressure falls below 50, your coronary artery perfusion may actually be compromised. So we want to make sure the diastolic, so your lower number, is above 50. We also may notice some different variations in the waveform depending on what's going on respiratory-wise, or depending on what's going on cardiac-wise. Well, so for the most part, you're not going to really see arterial pressure waveforms be varied by respiratory rate. That's because arterial pressures are substantially higher than intrathoracic pressures during breathing. However, when respiratory variations in arterial pressure waveform are seen, some of the things that we need to think about is there a tamponade going on, cardiac tamponade? Is there a paradoxical pulse, like what we would see in asthma? Dysrhythmias and pulsus alterans can also cause variations in the height and the shapes of the waveform. PEEP can alter waveform by alternating a strong and a weak pulse during sinus rhythm. That pulsus alterans is basically that the amplitude of the waveform differs with every other beat, and that can actually indicate severe ventricular failure. So this PowerPoint follows along with Chapter 15 really well, so if you need to go back and look at notes or read your textbook, novel idea. Alright, use of their arc line pressures to help cardiac output or to estimate cardiac output, and this is something that I talked about yesterday with that arterial pulse contour, the APC analysis. Okay, so monitors have developed algorithms that help calculate and display continuous beat-to-beat stroke volume and cardiac output based on the shape and area of the arterial pressure wave. Okay, this is considered to be minimally invasive because it is still an arc line, and an indirect method used to assess cardiac output by use of an arc line. Okay, and this is further discussed. There's like a little mini paragraph in it in chapter 15, but it's discussed more in chapter 16. So yeah, we kind of talked about cardiac output. We kind of covered 16 before we did 15. All right, looking more at the blood pressure. So if we our normal blood pressure is considered 120/80. This can increase gradually with age. If you are greater than 140 systolic and 90 diastolic, you're considered to have hypertension, or you're hypertensive. Okay. If you are below 60 or 90/60, then it's called hypotension, and this should all be reviewed for you guys anyway. But again, keeping in mind, some people's blood pressure runs low. Some people are just fine and dandy with a blood pressure of 90/60. They may feel just okay. My dad, he ran a low blood pressure. He was hardly ever over 100. I mean, that's just what worked for him. So, but just keeping in mind some of the things that you might see. If somebody is hypotensive, they'll probably have cold, clammy extremities, pale, mottled, okay, and think of things that could make you hypotensive. Hypovolemia should be one of the first ones that come to mind. Cardiac failure, an MI, sepsis, when they start to vasodilate. And remember, if they have a pressure diastolic less than 50, that can compromise your coronary artery perfusion. Okay, so remember those numbers. Hypotension, again, we just kind of talked about, can be caused by low blood volume, hypotension or hypovolemia, poor cardiac function, like an MI, CHF, low vascular resistance, and again, so the diastolic less than 50, or a mean also less than 60. So a mean blood pressure less than 60. Two important numbers to know. Hypertension, on the other hand, is caused by improvement in the circulatory volume and function. Also can be a sympathetic stimulation, fear, medications, vasoconstriction, administration of vasopressors that are going to bring your blood pressure up. This one's moving along pretty darn good, if I say myself. I thought maybe I would have a lot more to say. Okay, so looking at, we just have a couple slides left. I guess you'll have a shorter day today, a little bit longer day the next day. All right, so looking at pulse pressure, remembering that is the difference between your systolic and your diastolic, so you do the math, subtract them. Okay, a low pulse pressure is common when your stroke volume is low. We like to have a mean arterial pressure from about 70 to 105, keeping in mind that if it's less than 60, that is going to compromise our organs. And you should remember how to calculate your mean. The most common is taking your systolic plus your diastolic times 2, because you spend twice as much time in diastole, and divide that all by 3. Okay. If the pulse pressure goes up with fluid, okay, so if you administer fluid and the pulse pressure ends up going up, the patient was probably hypovolemic to begin with. Okay. A pulse pressure less than 30 indicates low left ventricular stroke volume. Just little tidbits more of information here. And there's your little equation. I know you kind of hear what the other one said, 70 to 105 for mean arterial pressure. I mean, let's just go with 80 to 100 because I think it's just a bit easier. Okay, so that's the average of pressures being pushing blood through the systemic circulation. It tells us how well our tissues are being perfused. Okay, so that is again examples of two different PowerPoints. That's kind of why they vary a little bit. The 70 to 105 was in your textbook, and the 80 to 100 is from a different resource. But you know, it should be at least 60. Okay, so just minimum of 60. Okay, I'm not going to get too hung up on the numbers there. So like I said, we multiply the diastole by 2 because more time is spent diastole. Again, if we have a low MAP, so for example, if our blood pressure drops below 60, we have to be concerned about our vital organs having enough circulation. So things that we would do to help treat this, I'm hoping you're saying volume, because that's probably the most common. Vasopressors, possibly, to help increase the blood pressure, or inotropic drugs to increase contractility. If we have an increased MAP, so let's say we are greater than 100 or 105, then that shows an increased risk of heart failure and stroke. Alright, so just like all type of invasive monitoring, these all have risks associated with them, as far as having an invasive line, ischemia being one of them, infection probably being the most common. Okay, the longer the line is in, the greater the chance of infection. So, you know, watching for fever. If you have ischemia, that can include happen with embolism, with thrombosis, or a spasm. So you would see if the skin was pale, distal to the insertion site, so you know, further past the insertion site. Pain associated could also be something that's going on. So this can result in tissue necrosis if you don't recognize it rapidly. Obviously, hemorrhage can also be a huge concern. If you have an 18 gauge needle, that can act, and if you don't, you know, close up off the stopcock, or don't have your lure lock or whatever connected tightly, you can actually lose 500 mils of blood in a minute. So a half of a liter of blood with an 18 gauge. So that is kind of scary. Okay, so wow, I kept that just a little over 30 minutes. So we will continue with part 2 tomorrow. Thank you.